Okay, let's jump right in. Welcome to a deep dive into sacroiliac joint pain, or SIJ pain.
Yeah, it's definitely a pain point that the research you've shared highlights as, well, notoriously challenging, both to diagnose
Yeah.
and to treat effectively.
Exactly. And we're drawing directly from your sources, the research, your notes for this. The mission really is to try and cut through some of that complexity.
Really give you a clear picture of what's actually going on.
Our goal here is to get you up to speed on SIJ pain quickly, how it typically presents, the underlying issues, why diagnosis can be so tricky, and then the treatments available.
And it's important because, like you said, the sources really hammer home how difficult diagnosis can be
Yeah.
and how differently it can show up from person to person.
So let's start right there. How does this pain usually feel? Where does it show up? What did the sources say about typical symptoms?
Well, what's interesting is it's often described as a deep discomfort, usually centered around the buttock area, and it frequently radiates kind of down the back of the thigh. Sometimes, according to research, it can even go as far down as the knee.
And certain activities seem to really provoke it, right? What does the material say makes this pain worse?
Yes, definitely. Activities that stress the joint are major culprits. Sitting for a long time is a big one, as is lying directly on the affected side. Things like climbing stairs, twisting the torso, or any axial loading movement.
What's that exactly? Axial loading.
Basically putting weight sort of straight down through the spine and pelvis.
Yeah.
So standing for a long time or, carrying something heavy, those can significantly aggravate the pain.
Okay. And I saw in the sources that while, yes, traumatic events happen, things like car accidents, falls, maybe repetitive stress, even pregnancy.
Right. Those are identified as triggers in a fair chunk of cases, maybe 40-50% of confirmed SIJ pain.
But the research suggests it's actually more commonly something that just creeps up, develops slowly, often related to overuse maybe, rather than one big event.
That insidious onset, yeah. And that, plus the wide variety of triggers, really underscores why diagnosis is so tough.
Yeah.
Just based on hearing someone's story.
And speaking of variability, the sources you provided, including data from that slip-in study, they give some really specific numbers on where people feel this pain.
They do. 94% reported buttock pain. That makes sense. It's right there.
Right.
But then 72% also had lumbar or lower back pain, which can be confusing.
Yeah, it definitely points you in a different direction.
And half experienced radiation into the lower extremity. Nearly 30% had pain below the knee.
Wow.
Which can really mislead people into thinking it's sciatica from a disc or something else entirely. And then 14% even felt it in the groin.
Wow, those stats really highlight how much SIJ pain can mimic other common stuff, like sciatica or a low back disc problem. It's no wonder it's tough to pinpoint.
Exactly.
And for athletes, it sounds like the uneven demands of certain sports put them at higher risk.
Absolutely. Activities involving that repetitive, uneven loading, think kicking a soccer ball over and over, swinging a golf club or a baseball bat, throwing...
With javelin or discus.
Yeah, or even just prolonged standing on one leg, which happens in certain sports or dance. That can place imbalanced stresses on the SI joint over time, making athletes more susceptible.
So that's how it feels and presents. Now let's get into what's actually happening at the joint level. What does the research say about the pathophysiology?
Well, at its core, the issue is typically inflammation or some kind of injury affecting the structures of or around the SI joint itself.
Okay.
So this could be damage to the joint capsule, those strong supporting ligaments, or even the bone just underneath the cartilage, that's the subchondral bone.
And your sources break down the potential problems into categories, right? Sort of inside versus outside the joint.
They do, yeah. It's helpful to think about issues happening inside the joint that's termed intra-articular. This might involve, say, disruption of the joint lining or the capsule, or maybe alterations in how the joint surfaces move together, altered mechanics,
Right.
or excessive tension on ligaments, cartilage damage, or even in some cases, subtle fractures.
Okay, so stuff within the joint boundaries.
Exactly. Then there are issues happening outside the joint, but still affecting its function and causing pain, the extra-articular problems.
Like what sort of things?
This could be abnormal joint mobility, meaning the joint's either moving too much, hypermobility, or not enough, hypomobility.
Okay.
Or external forces like compression or shearing that overload the joint. Injuries to surrounding soft tissues like muscles, or even just widespread inflammation in the area can also be extra-articular causes.
Okay, so given that wide variety of symptoms and the fact that the problem could be inside or outside the joint, it sounds like the diagnostic process is anything but straightforward.
Tricky is putting it mildly.
Yeah.
This is where the sources highlight a really crucial point. Just relying on the patient's history, the physical exam findings, or even imaging is often insufficient for a definitive diagnosis. The variability just makes it too easy to guess wrong if you don't actually confirm the source.
So when someone goes in, what specifically are clinicians looking for during a physical exam that might point towards the SI joint?
Well, a key part is palpation, actually feeling for tenderness directly over the sacral sulcus. That's the little groove right next to the sacrum where the SI joint sits.
Okay.
Beyond that, they'll perform what are called provocative maneuvers. These are specific movements or tests designed to stress the SI joint and try to reproduce your specific pain.
Like trying to make it hurt, basically.
Essentially, yes. To see if stressing that specific joint brings on the familiar symptoms. The sources mention several, like the Faber test that involves flexing, abducting, externally rotating the hip.
Right.
There's also the posterior shear test, resisted abduction, the standing flexion test, and the Stork test. These all help assess how the joint responds to different kinds of load.
And does imaging, like X-rays or MRIs, help clinch the diagnosis? Or is it more complicated?
It's definitely more complicated. Imaging can give some clues, but its usefulness is, well, limited depending on the underlying cause.
Okay.
Standard pelvic X-rays often don't show the joint very clearly because other structures get in the way.
Right.
MRI is actually quite valuable sensitivity, over 90%, but mainly for detecting inflammatory conditions affecting the joint, like sacroiliitis.
So if it's not inflamed, MRI might miss it.
It's much less useful for mechanical, non-inflammatory SIJ pain, yes. CT scans offer kind of moderate diagnostic accuracy. The sources cited something like 57.5% sensitivity and 69% specificity.
Which means?
It means they'll miss a fair number of actual cases and sometimes incorrectly identify SIJ pain when it's not there. Not perfect.
So if the symptoms are all over the place, physical tests are suggestive but not definitive, and imaging has these limitations. How does a clinician confirm that the SI joint is the actual pain generator?
This is where the research you shared points towards the gold standard. A diagnostic sacroiliac joint injection.
Ah, the injection.
Right. By injecting a local anesthetic, just a numbing agent, directly into the SI joint. And they do this under imaging guidance, like fluoroscopy or ultrasound, to make sure they're exactly in the right spot.
Okay.
You can see if temporarily blocking the signals from that joint significantly relieves the patient's pain. If the pain goes away or is substantially reduced right after the injection, it strongly implicates the SI joint as the source.
Okay, that makes sense. So let's say the diagnostic injection confirms it, the SI joint is the problem. What does the research suggest are the next steps for treatment? Starting with conservative options.
Right. The initial approach is typically conservative therapies. This includes using medications like topical or oral NSAIDs, non-steroidal anti-inflammatories.
Like ibuprofen.
Exactly. Or acetaminophen for pain, maybe muscle relaxants to ease some associated muscle tension. Activity modification is also really crucial.
Figuring out what makes it worse and avoiding it.
Yeah, figuring out which movements or positions aggravate the pain and trying to avoid or alter them.
And physical therapy seems to be highlighted as a really core component of conservative care.
Oh, absolutely. It's described as a cornerstone treatment. And the data cited is pretty impressive, suggesting it can lead to improvement in up to 95% of patients.
Wow, 95% is huge.
It is. The focus in PT is on optimizing the mechanics of the lumbar spine, the pelvis, and the hip, making sure these connected areas are moving efficiently and not putting undue stress on the SI joint. And it's considered very safe when supervised by a qualified professional.
What about manual therapies like manipulation, chiropractic, osteopathic stuff? Is that consistently effective according to the sources?
Well, those manual techniques are sometimes used. However, the sources do note that the well-designed studies looking at these specific techniques haven't consistently demonstrated significant benefits specifically for SIJ pain. So the evidence there is a bit more mixed or lacking.
Okay. So if conservative measures like PT and maybe meds aren't providing enough relief, what are the next level options, the procedural or interventional treatments discussed in your research?
Right, there are several tiers here with sort of varying levels of evidence behind them. Techniques like prolotherapy.
What's that involve?
That involves injecting solutions, often a dextrose solution, to try and stimulate tissue repair. Some studies have shown some early symptom improvement with that compared to corticosteroid injections.
Okay.
Then there's platelet-rich plasma, PRP. That's derived from the patient's own blood. There's some suggestion it might offer superior outcomes at 6 and 12 weeks compared to steroids, but the data there is still pretty limited.
Still emerging evidence, maybe.
Exactly. And mesenchymal stem cell use, according to the ASCP guidelines mentioned in the sources, that's the American Society of Interventional Pain Physicians, that's currently still considered experimental for SIJ pain.
Got it. Now, corticosteroid injections are probably the most widely known interventional treatment. What does the research say about how well they work?
Yeah, steroid injections are typically used when the more conservative options like NSAIDs and PT haven't cut it. Your sources indicate they're significantly more effective when they're guided by imaging again to make sure the medication gets right into the target spot.
Makes sense.
And especially when they're combined with physical therapy, it's not just about the shot. It's about using that window of pain relief to make progress with PT.
And does it matter if it's in the joint versus around the joint?
Generally, yes. Intra-articular injections right in the joint space are usually thought to provide greater pain relief than peri-articular injections, which are just around the joint.
Okay.
Interestingly, though, both intra- and extra-articular injections do show better results than placebo. And there's even some limited evidence suggesting that peri-articular, the injections around the joint, might actually be surprisingly more effective in certain situations. Still needs more research, though.
Huh, interesting. And for longer lasting relief, especially if those injections work but then they wear off fairly quickly, what's next?
That's where techniques like neurolysis or radiofrequency ablation, RFA, come into play.
Sounds intense.
It's a procedure aimed at the nerves. This approach is considered best for patients who've already had a positive response to those diagnostic blocks we talked about, confirming the joint is the pain source.
Right. Proof of concept first.
Exactly. It involves using methods like heat, sometimes cold, or chemical agents to essentially lesion or block the small sensory nerves that supply the SI joint with pain signals.
Kind of interrupting the pain message.
Precisely. And some studies cited do note that these procedures can lead to reduced pain, less disability, and even decreased opioid use in the right patients.
Okay. This brings us to prognosis and long-term outcomes. What does the research say about how people generally do over time with these different treatment paths?
This is where some of the findings in your sources are particularly striking and important. The long-term outcome really seems to vary quite significantly depending on which treatment path is taken.
How so?
Well, one study mentioned specifically by Vanna Klosha and colleagues looked at patients managed just conservatively over 6 years.
Okay, a long time.
Yeah. And they found no sustained improvement in pain or disability over that entire period.
No sustained improvement. Over 6 years.
That's what that study reported. And not only that, but those patients also saw an increase in opioid use and reported poor work outcomes over that time.
Wow, no sustained improvement with just conservative management alone. That's a really powerful finding from that particular study. So, what are the alternatives if conservative care isn't providing that lasting relief?
Well, based on your sources, minimally invasive surgical techniques, specifically SI joint fusion, are presented as potentially favorable alternatives compared to the older, much more involved open surgical fusions.
Less invasive fusion.
Right. The research highlights benefits like reduced tissue damage, less blood loss during the surgery, shorter hospital stays, and importantly, better pain outcomes at 12 and 24 months compared to ongoing conservative management.
But even minimally invasive surgery isn't risk-free, correct? There are still potential downsides.
Oh, absolutely. And that's crucial to acknowledge. While the benefits are noted, complications still occur with surgery. The sources cite complication rates around 21% for the older open procedures and about 18% for the minimally invasive ones.
Still a significant number.
It is. However, despite this, the overall long-term results and complication profiles seem to favor the minimally invasive techniques over both conservative management alone, based on that Vanna Klosha study, and the older open surgery methods.
Okay. Let's quickly round out by just mentioning some of those potential complications, both from the underlying SI joint dysfunction itself and from the treatments.
Right. So beyond the chronic pain and the difficulty getting back to work or sports that the SIJ dysfunction itself can cause, surgical interventions carry specific risks.
Like what?
Things like developing new pain in the facet joints of the spine nearby, or getting trochanteric bursitis near the hip. Deep wound infections are a possibility, or even new low back or leg pain that wasn't there before the surgery.
Are there other potential issues mentioned in the sources, like less common ones?
Yes, there's a range of other possibilities cited. Things like superficial cellulitis, which is a skin infection, radiculopathy, or nerve root pain, piriformis syndrome, which is nerve compression in the buttock area.
Okay.
Even things like vascular necrosis of the hip, that's where bone tissue dies off.
Mm-hmm.
Issues related to the implant itself affecting nerves, implant-related neural compromise, broader peripheral neuropathy, non-displaced fractures related to the procedure itself, and even serious things like thromboembolic events, blood clots like DVT or pulmonary embolism.
Wow.
Yeah, it really is a complex joint and a complex area with a whole set of potential issues and risks depending on how it's managed.
So, pulling all these threads together from this deep dive into your sources, sacroiliac joint pain is clearly a challenging puzzle to solve definitively.
Absolutely.
Conservative treatment alone might not offer long-term relief for everyone, based on some key studies like the one we mentioned.
Right, that's an important takeaway.
And while there are various interventional and surgical options with evolving evidence, they definitely come with their own potential complications that need to be weighed.
It's all about weighing those risks and benefits for the individual.
Which leaves us with an important question for you, the listener, to consider. Given this really complex diagnostic journey that's often required just to pinpoint SIJ pain, and the significant difference in long-term outcomes that some research highlights between purely conservative approaches and certain interventional options, what's the single most important first step you should take if you suspect SIJ pain might actually be your problem?
Something to definitely think about.
Something to chew on. Thanks for joining us for this deep dive into your sources.